Today we're going to talk about hemodynamics, predominantly in the ICU. From today's talk, I want you to understand concepts and basics and not memorize a lot of things. And hopefully you'll be able to think about what we need to learn as we go through this. So in the ICU, we predominantly use a Swan-Ganz catheter, but we can use other catheters as well, and we get the same information from a right heart cath. The catheter, I have lost my, here we go. Sorry about that, has a balloon on it so that the balloon is at the end, and that helps us float it. It also, if we advance it way up into the pulmonary arteries, we can get our wedge pressure, and we'll talk about that in a minute. There is a pressure transducer at the very end, and the balloon is behind that, and that's important to remember once we get to the wedge pressure. Swan-Ganz also has a thermometer port on here, and so that will be important as well. This diagram, even though it's fetal circulation, is to help us look at, where the vessels are coming from. So up above, we have the SVC coming into the right atrium, and we have an IVC coming into, wow, my thing is very sensitive here, the right atrium. If you notice, flow will go into the right ventricle and out into the pulmonary arteries. If there is a patent frame in ovale, which you see on the screen, there will be a connection between the right atrium and the left atrium. That's not common. And then as we go up into the pulmonary artery, we're going to estimate backflow from the left side of the heart once we wedge things. We will be getting arterial sat, so where the aorta is also important. And in general, before we do a right heart cath, we want to use supportive data that we have. So this is an echo picture, and this person has a tremendously enlarged right atrium and right ventricle. And this is somebody you're probably going to have difficulty floating a swan just by pressures. And so this is somebody you might want to use fluoroscopy with. But use data, whether it's CT scans or other imaging you have, before you get started so you know what you're doing. We want to know what the question is before we start. So whether it's a swan or right heart cath, know what we're looking for. Do we think there's pericardial disease? Do we think there's heart failure? If so, is it left or right heart failure? Are we looking to help diagnose pulmonary hypertension, and whether that's primary or secondary? Are we looking for congenital heart disease, either because we know it's there or there's some clue in imaging or something else? Are we in the ICU and we want to manage volume? Is there a GI bleed? Is there trauma or sepsis? Is the patient on pressors and we can't seem to fix things? All are good reason, but you need to know what you're asking before you get in there. There may be valvular heart disease. We just may want to know what the back pressure from the left heart is. Or we may want to assess response to treatments. Typical things that we'll be looking for in the ICU often are sepsis, high output, low output, and mixed metabolic things. And I think the important thing to remember is that many of our patients that end up in our ICUs, especially here at Duke, are not straightforward. They're not normal at baseline. And so whatever is going on now also is being colored by whatever their baseline disease is. So there may be two opposing conditions, i.e. heart failure with low output and now sepsis with high output, and you have to be able to sort that out. Once we do the procedure, we want to make sure that everything makes sense. Do the numbers make sense? Are the pressure tracings that we get good? The calculations make sense? Make sure they're internally consistent. Have we answered the question? And if we have we raised some other problems? Leave your catheters where they are until you really understand what's going on. Now, if you're in the ICU, you may be leaving it anyway. And have you either made a diagnosis or have you refined it in some way? You may have created more questions, and then you have to answer those as well. Is your output what you thought it should be? And if it isn't, you have to think about why. So again, you might have an echo beforehand and you say, wow, they had a normal ejection fraction and we're getting a low output. Can you explain that? And there are reasons to explain that, but again, we have to be able to think. In order to think, we have to understand what's going on. If the output seems very high, we may need to do a saturation run or a shunt run. Again, a little bit more difficult in the ICU, but it can be done. We should do this if our AVO2 difference is very low, or if our PA sats are very high. If we get in there and we find that our pressures are equalized, so RA pressure is the same as all of our diastolic pressures and our wedge pressure, then we may need to decide if this is constriction or restriction. So how do we get the data? When we go in, we want to get both pressures and saturations. Different pressures, we're not often going to get an IVC or wedge pressure of the liver while we're in the ICU, but you're certainly going to get an RA pressure, which is another word for CVP. You're going to get a right ventricular pressure, float out to the PA pressure, and then get a pulmonary capillary wedge pressure or a pulmonary artery occlusion pressure. Those are the same, and you'll see them differently in different books. An LVEDP if you're in the cath lab. Remember that a wedge is supposedly estimating a left atrial pressure as long as we're assuming there's not valvular heart disease. Okay. Other things that we're going to get are saturations, and so we can get high and low SVC sats or an innominate sat. We can get sats in the RA, again, either high or low or just a plain right atrial sat. We're going to get a PA sat, and if there are no shunts, that's what we use as our mixed venous sat. We can get RV and LV if we need to. We want to get pulmonary capillary wedge sat on occasion, and that's not common. If there is some sort of a shunt, we may be able to get a pulmonary vein. Again, that's going to be unusual in the ICU. If there are anomalous veins, we might get that. Again, we may get extra things if we need to sort something out, and those are atypical in the ICU. But mostly we need the mixed venous sat, which is our pulmonary arterial sat, and we need the arterial sat, which could be from an A-line in the arm or in the leg. These are what your tracings are essentially going to look like. On the top part of the screen, the chambers are listed, so the right atrium, right ventricle, pulmonary artery, and wedge. There's pressure coming down the side, and you can see that as we move the catheter through into the right atrium, we would measure pressure. We get very small waveforms in the atria because the chambers are very thin and contraction is not very forceful. As we move into the right ventricle, because it's a muscular chamber, we see a rapid upstroke and a rapid downstroke, and that downstroke comes very near to zero. As we move out into a great vessel, in this case the pulmonary artery, our shape of our tracing turns into a triangle, and that's because there's elasticity of the vessel. And then as we move into a wedge position, it's a little higher than our right atrial pressure, but again, not terribly high. And if you notice, the wedge pressure is approximately the PA diastolic if somebody is normal. Not the case in many of the patients that we will see. And this is another way of drawing the system. If we look in the middle of the screen in the blue, meaning deoxygenated blood, we have our right atrium toward the top and our right ventricle at the bottom. Normally, pressures in the right atrium are sometimes 2 to 5, 2 to 7. You're going to see different levels in different books, but you can think of RA as being a pressure of 5. RV, again, you have a strong squeeze, so systolic pressure is going to go up to 25. When it relaxes, it should come down to whatever the right atrial pressure was. So again, 5. And you can see there's a valve between there. When that valve is open, those pressures should equilibrate. The RV pumps into the pulmonary arteries, and again, now there's elasticity, so the diastolic pressure doesn't come down as much. And when we push and wedge that catheter, we're getting pulmonary pressures back from the left side of the heart, and we assume those. Remember that our wedge pressure is going to be whatever our LV EDP is, again, if those valves are normal. And we can transit the blood. The other thing that happens here is that we are measuring output, and the pulmonary circulation has to equal the systemic circulation. So whatever pumps through the right side of the system, the same amount of blood pumps through the left. So your cardiac outputs have to be the same on both sides. And we measure those things. So we need pressures, we need saturations to help us measure cardiac outputs. Again, these are just normal pressures. So the right atrial pressure of 5, Think of an RV systolic pressure and PA systolic pressure as 25 and a wedge of 10. So nickels, quarters, and dimes is a good way to remember it. As a quick conversion, in the ICU, we often use dynes as our unit of resistance, and if you divide that by 80, it's going to give you wood units, and we'll see that a little bit later. Cardiac index, we'll talk about that a little bit, will tell you a little bit about cardiac output if we make everybody a standard size, and normal values are about 3.5 liters per minute per meter squared. Again, our resistances, systemic vascular resistance, is going to be 600 to 900 dynes. Divide that by 80 to get your wood units, and a PVR, or pulmonary vascular resistance, is very much lower. It's not all about numbers. So when we start the procedure, we need to make sure everything is correctly zeroed. So all the transducers and all the catheters have to be flushed and make sure there's no air bubbles in them. If the patient is lying supine on their back, and even if you elevate their head, the catheter should be zeroed such you're in the mid-axillary line. So put the catheter in the armpit of the patient, basically, and that's where your zero should be. If somebody's very thin, laying it on the bed is similar. If they're much thicker in their torso, that may not be correct. If you have damped tracings, and we'll look at some tracings, make sure they're not air bubbles. We want to look at the numbers themselves, but we also want to look at the waveforms, because the shape of those waveforms tell us a lot about the patient as well. And again, we're going to then measure saturation so we can calculate outputs. And those may be FIC outputs or assumed FIC outputs. We can also use a thermodilution system. Again, occasionally we're measuring shunts, not often. We're going to get the resistance, and we're going to calculate that from the pressures and the outputs that we have measured. The waveforms are going to look different. And again, I don't need you to remember or memorize all of this stuff, but I want you to think about, you're going to get waveforms from each of these places. You need to be able to assess or understand what happens if somebody is breathing in or out, whether there's something wrong with a certain chamber, or if pressures are high or below, above or below that chamber, because it's going to change things. Things that you see might help you make a diagnosis. One other thing, you're also going to use the EKG, and again, on the tracings, I'll show you to time things so you can tell which waves are which. Again, I don't want you to remember that or memorize any of this, but for you to look through and understand. The chamber compliance itself, whether the valves above or below it, and the chambers above and below it, as well as heart rate and respiration, all are going to play a role in how things look. Normally, we should see that when there's a decrease in pressure is during inspiration. At end expiration is where we should really measure the pressure. If the patient is on a ventilator, that's opposite. So there's positive pressure ventilation. So when they inspire, pressure is going to increase a little bit. Other things will change, and again, the steady state that's going on will be very relevant. You'll see again in the tracings that we show that these variations are important. You need to basically be able to recognize whether the tracing is an atrial tracing, whether it's left or right, and we'll call the wedge an atrial tracing, whether it's a ventricular tracing, or if it's a great vessel tracing. So this is a little schematic of what you'll see on things. So in the top is an EKG, and the A wave should then go with atrial contraction. So there's a little P wave in the EKG, and that goes with atrial contraction. Electrical activity then occurs, which should start off systole, and then V wave follows that QRS complex, and it kind of comes almost at the end of the T is where you're going to find it. So if you're trying to sort out what's an A and a V wave, you need to time it with an EKG. This tracing is actually from a patient with a lot of pulmonary hypertension, but this is what a ventricular tracing should look like. Again, pressure is on the side, and it goes from 0 to 200, and that's very changeable. So you can set that from 0 to 20, or 0 to 40, or 0 to 25, or 50, or 200, and the scale is very important. Time is going along the bottom of the screen. There are 2 EKG leads at the top. And so again, if you time things, the systolic or rapid upstroke of this ventricular pressure that you see comes after the QRS complex, and then that is systole. The quick decrease in pressure is diastole, and then there's some filling at the bottom. It should be round at the bottom like this, and this is actually an RV tracing. It looks more like an LV tracing, but either shape is approximately the same. This differs from what a great vessel looks like. So a great vessel is either your pulmonary artery or your aorta. This tracing looks like a typical aortic tracing, so pressures are about 140 over, say, 60 diastole, and the computer is making an average mean there by sampling the area under the curve. So the curvy line in the middle is the mean pressure. Again, this is really a PA tracing in somebody who's very abnormal, but it looks just like an aortic tracing. If we put those two things together, and we have a ventricular tracing and a PA tracing both being measured at the same time, you'll see that the PA systolic pressure or the aortic systolic pressure and the ventricular systolic pressure are the same, but diastole is different. And again, that's the elasticity of the vessel. This means that there's no valvular problem between those two chambers, if you want to call them. So the ventricular pressure is equal to, the ventricular systolic pressure is equal to the great vessel systolic pressure. This is a RA tracing that doesn't look exactly like a right atrial tracing, but again, the point of this is to show you that pressures are very different. So on this tracing, pressure is 0 to 50. There's EKGs at the top, time goes along the bottom, and for every EKG spike, we see that there's a waveform. In this case, there's a big CV wave. The right atrial pressure is high. It's about 20 and not the 5 that it ought to be. This is an aortic tracing again. So rapid upstroke with following the QRS complex and then comes down. And so this pressure would be 190 over just under 100 with a mean of 130 or 135 or so. A PA tracing, again, very high, but the same exact shape. This is another RA tracing, and again, you can time. There's a small P wave in the EKG, and the first glitch after that is actually an A wave. There's a delay before you get the C wave or V wave, and so in this person, the A wave is higher than the V wave is, and the mean is a little bit high, it's 14, but different shapes. Again, you need to learn to time it. A very abnormal tracing, and I'm telling you this is an RA tracing in a patient, and this is a real tracing from a real person. So the scale is 0 to 25. Again, normal for an RA would be 5. So grossly abnormal. Again, there's a big CV wave in this person, so probably tricuspid regurgitation, so a lot of flow goes backwards into the atrium. You see a steep Y descent, so when the person breathes in and out, you see these big dips coming down. So again, the shape of the tracing itself tells me a lot about the patient, more than just knowing that the pressure is 25, which is abnormal as well. This is also a right ventricle tracing. Now again, it's not perfectly round at the bottom like that other one was. And again, even though if I know systole is about 50, the bottom diastolic number is going to be in the teens, but end diastole is probably as high as 20, and it's that end diastolic pressure, so that sort of upstroke glitch just before the strong upstroke. And this shape tells us that there's rapid filling with rapid pressure going up, and so it's a non-compliant right ventricle. A left ventricle would look the same if there's some sort of heart failure going on. So the shape tells me more than just the pressure itself. Again, this is an RV with round at the bottom, which is more normal than going back here with that rapid upstroke or that square root sign. So that square root sign can be in heart failure, it can be in constriction or restriction. It's not specific. Again, one more PA tracing, although pressures are a little bit lower, still high, but that same triangular shape. There is a dicrotic notch, so on the down slope you see this little glitch, and that's the closure of the pulmonic valve. On an aortic tracing, the same thing happens. And this is a wedge tracing. So again, very much less swing in our tracing. So the chamber that you're in is not really a chamber. You're now distally in the pulmonary artery and you're transducing pressure backwards. So there's much less sharp upstrokes. Again, the overall pressure is not normal, so this is 0 to 50 scale. This person's wedge is probably a mean of 30. And you can see the flat part at the top is end expiration. You see these little dips coming down, and that's when the person breathes in, you decrease interthoracic pressure. So we would be picking a number along that flat part as our mean. Another wedge tracing, and this person, again, had a lot of respiratory variation. Again, the wedge is not too high, so this is more of a normal wedge pressure. He nicely had a little bit of apnea in the bottom tracing, and it kind of leveled out for us, and so maybe we'd call this wedge about 12 or so. And you can see small A and V waves. One other wedge tracing, in the top screen, the person is bearing down a little, so it never flattens out. It has this slow rise going up, and it would be hard to pick a wedge. In the bottom tracing, we can sort of see some flat level areas, so wedge is about 25. Again, these big dips are inspiration. It's important here to know what you're picking for the wedge, because there's a big difference between saying somebody's wedge is 35, or if you pick the bottom of those inspiratory things, you'd be saying the wedge is 5 or 10, and that would be absolutely wrong. You have to make sure your wedge is not damped. So if you're getting numbers that don't make sense or that don't look right or don't have some, kind of up and down in them, or there's no respiratory variation, you can ask the patient to breathe in and out and make some. You can try to withdraw blood from it, and you should get a high sat. It's very hard to draw a wedge sat. It doesn't pull back easily. You can check another area if you get a wedge that, again, seems unlikely. If you're not sure in the cath lab, you can go in, get arterial access, and go in and get an LVEDP. There are different shapes that we'll see on some other tracings which tell us different things about what's going on with a wedge pressure. The last thing we want to know about the tracings themselves is that heart rate can affect it, respiration can affect it, rhythm can affect it. If you look at the EKGs, on the top there's sort of a fairly steady rhythm until you see the last few beats, and then there's a fast, narrower complex, and on the bottom row there's also some fast, narrow complex. When you see that fast, narrow complex, the overall pressure is lower. When there's a pause in the EKG, you then see lots more filling time, and then you see a high pressure. So there's some respiratory variation going on, and then there's a difference between peaks and valleys because of the rate of the EKG. So if somebody's very, very tachycardic, they may have very much lower pressures because of this. The next tracing shows us similar things. So here we have a beat, and then we have an early beat or PVC, and then there's a delay. After the delay, the tracings are higher because there's more filling time and more pressure. If the beat comes too quickly, there's not enough filling time, so the second beat is much lower in terms of pressure. On the bottom tracing, you can see that the heart rate gets very fast at times, and when that happens, blood pressure is very low. So if that were your left ventricular pressure on the screen, you could see that the person's blood pressure could be very low with persistent tachycardia or with VT or something like that. So abnormal pressures. So we've gotten pressures, we got tracings, and then we need to know, are these normal or not? Is it the 5 that we expect if we're in the right atrial pressure? If it's not, that's when we need to sort out why it might be. So what causes high right atrial pressure? So pulmonary hypertension, right heart failure of some sort. Now, the biggest cause of right heart failure is left heart failure, so plenty of reasons for that. A pulmonary embolus, and if they've gotten volume, constriction, restriction, tamponade, lots of things can cause a high right atrial pressure. High wedge pressures, again, heart failure is the predominant thing because it's common. So whether it's systolic heart failure or diastolic heart failure, they may look very much the same. Mitral disease or aortic disease can cause high left-sided pressures. And again, depending on chronicity or how high those are, they may cause high rate atrial pressures. Hypertrophic cardiomyopathy, shunts, if you have a lot of flow going from right to left and emptying into the left atrium, you may have high pressures there. And again, tamponade, restriction, constriction, all together will raise all of these pressures. So once you get the pressures, you need more information to figure out why that is. The second thing we get after pressures are to figure out what are our cardiac outputs and cardiac index. Again, the cardiac index is a way of making everybody the same size. So a very large person, 6'5", has a higher cardiac output than somebody who's 5'5", but if they're both normal, their index is about the same. So if we're going to do a thick cardiac output, we have to obtain saturations in the arterial system, and we have to get a mixed venous sat. So preferably the PA if there's not a shunt, and then you can get it from whatever arterial line you have. When you're obtaining these, it's very important that you pull enough waste out, because whatever's in the catheter, including flush or blood from previous chambers, has to be pulled out. You have to make sure if you draw that blood that there's heparin in your syringe so that it doesn't clot. You have to make sure there's no air left in it, and if it's going to be sent out, it should be iced if it's not going to be run very quickly. I think that the biggest error in the ICU in terms of drawing sats is that we put our catheters out and we leave them pretty far out in the pulmonary artery, and as we pull back, we may be causing some sort of partial wedge pressure. So if you're getting sats that seem much too high to explain, you may need to pull your catheter back to the main pulmonary artery and repeat those. So very high sats are often or partially wedged, and that's a very common problem. Okay, we should find that our cardiac output should go along with what we think the physiologic and metabolic demands are. So if somebody is very sick, there should be a high cardiac output unless there's some other thing to make that low. So make sure, again, that your numbers make sense. Let's review the calculations and the things that we obtain. So cardiac output, and sometimes that's abbreviated as Q, sometimes it's CO, depending on which source you're looking. We usually measure cardiac output in liters per minute. Again, some equations may be milliliters per minute. You have to make sure you convert everything together. So cardiac output is oxygen consumption, and oxygen consumption is very rarely truly measured in terms of putting a mask on someone and measuring how much oxygen they take in and how much carbon dioxide they put out. But we often assume oxygen consumption, and there's different ways to do that. And it's oxygen consumption divided by our arterial to venous oxygen difference times 10, and the 10 is to make up for milligrams per deciliters that we use to convert over to liters. Cardiac index, we just take our cardiac output, we divide by body surface area. So your body surface area, there are several different equations, a Gault equation, other equations where you can punch into a calculator, basically height and weight, and it'll come up with a body surface area. So it might be 1.95 or 2.1 or 2.4. The bigger someone gets, the bigger that is. AVO2 difference, so again, the difference in our sats between our arterial sat and our venous, our mixed venous sat, that difference, we look at arterial contents. So content of blood is not just the saturation itself, but it has to take into account other things. So our oxygen saturation in our arterial system is going to, say, be 95. So we'd say it's 0.95. In our venous system, it's maybe 75% or 0.75. We're going to multiply that by a constant in 1.34 and by the patient's hemoglobin. So hemoglobin, as you recall from medical school, doesn't carry oxygen 1-to-1. So it's a pretty mixed ability, and it binds, the more it binds, the quicker it binds. So it's 1.34 times the hemoglobin, and then this change in sats. So it's very different if you have somebody with a hemoglobin, say, of 18 and their sat is 90 and 70 versus someone whose hemoglobin is 8 or 6 because they're anemic and their sat is 90 and 70. Because that extraction is very different, right? We all need a certain amount of energy to go to a muscle bed, and that oxygen that's delivered depends on the sat that gets there, so the oxygen, as well as the capacity to carry oxygen, and that's our hemoglobin. Again, we're going to use our PA sat, our pulmonary artery sat, as our mixed venous. If there's a shunt, then we cannot use our PA sat if there's an intracardiac shunt. And then we're going to take our SVC sat if it's before the shunt. So if the shunt is, say, in right atrium or right ventricle, we can use 3 times your SVC sat plus 1 times your IVC sat, divide that by 4, and that's then your mixed venous. Again, not a common situation, but occasionally that is the case. So you have to know where the sat is or the shunt is. The next thing we calculate, so if we have output, the other thing we want to know are resistances. And we want to know resistances because that helps us figure out, is this heart failure? Is this sepsis? Is this some combination? So resistance, if you remember, is change in pressure over flow from your days of physics. And you can switch that around. Flow is change in pressure over resistance, however you remember it in your mind. So if we think about pulmonary vascular resistance, we want to think about the change in pressure across the pulmonary bed. And so the pressure going in is your mean pulmonary artery pressure that you've just measured. The pressure going out is your wedge pressure that you've just measured. And you divide that by flow. And flow is the cardiac output that you've just calculated. Okay. SVR is the systemic vascular resistance, so around the body. So mean aortic pressure minus what's at the end of the other systemic system, your right atrial pressure, and again, your cardiac output. Again, your pulmonary output and your systemic output should be the same unless there's some sort of shunt. You'll also see in heart failure and some other books something called transpulmonary gradient. So mean PA pressure minus your wedge is sometimes used in some of the literature instead of pulmonary vascular resistance. We're not going to talk a lot about that today. Some of our data, again, is measured, some of it is calculated. And the more things that we calculate, the less pure our things get. So we're actually measuring pressures, we're measuring oxygen saturations, we're starting to use those things to make calculations of outputs and consumptions and things like that. So they're not perfect measurements, and the more things that we assume, a little bit more dirty that they get. Okay. There are lots of tables, and some of those tables are put into the computers that we use in the ICU to use assumed consumptions for an assumed FIC. They're based on age, sex, body size. Some of them, so height and weight are included. The more normal someone is, the more average someone is, the more correct they are. If somebody weighs 500 pounds and is 5 foot tall, we don't have a good estimate of that. But again, if we're going to compare that person to themselves over time with our SWAN, it's okay if we don't have the exact right output. There are some estimates you can use, so if you get data from somewhere else and you don't have their same tables, we can use these 125 mLs per minute per meter squared for somebody's body size to assume an oxygen consumption, or 3 mLs per kilogram is another way to assume resting oxygen consumption. Other things that come up. So sometimes we're using something other than our pulmonary arterial sat, either because we can't get there or we don't have the SWAN there, again, to make assumptions about things. If you're getting an IVC sat, it's typically higher than your superior vena cava sat, mostly because there's a lot of blood flow to the kidneys, but the kidneys use a lot less oxygen. So there's high flow to the brain, it uses a lot of oxygen, so that sat is lower. So if you're getting, as a quick and dirty, a sat from a central line and it's up in the SVC, that's going to be a little bit different than if you're getting one from a line that's down in the groin. And it's okay to use either thing as long as you understand that and you don't compare one to the other. Okay. In a normal person, that AVO2 difference that we're talking about is about 20 volumes percent. Again, my arterial sat is 95, my mixed venous sat is 75. There's a 20% difference there. If for some reason I'm hypoxic and my sat is 80, then my venous sat, if I have normal output, is 60. Okay. What's different is that if somebody has low output, we then change that AVO2 difference, and we'll see some of that. So my oxygenation is normal and my sat is 95%, and I have low cardiac output, so I'm delivering less and less flow to my muscles. My muscles need to extract more and more oxygen, so the sat that comes back to my heart, that mixed venous sat, is now going to be a lot less, i.e., 40 or 50 or something like that. Okay, so measuring those sats is a pretty pure way, even if you don't calculate all the outputs and things, as long as you keep other things constant, i.e. the hemoglobin of the patient. If it's falling day after day, then you can't use that. Obviously, within a few hours, it's the same if you're giving the same amount of oxygen. So you can't start increasing the amount of oxygen you're sending, because that will change things. The other way to measure cardiac output, and again in the unit we sometimes do this, is thermodilution. So you're going to add some substance into the proximal port of your catheter, which is in the right atrium, and that substance is usually just cold water. It could be cold sugar water or cold saline. The same would work if you were using dye and measuring the color of that dye, but since we have thermistors on our ports, we add cold liquid, and then we measure it over time as it appears to be temperature change at the distal port, which is out in the pulmonary artery. This will create a curve, and I'll show you some of these curves. And the area under the curve is inversely proportional to the amount of flow or cardiac output. Again, if you're delivering it very quickly, and it gets there and it decays very quickly, it's a high output. If it gets there very slowly and clears slowly, it's a low output, but the area under that curve would then be big. Thermodilution assumes that there's no shunt. So if there is a shunt, you can get very abnormal findings. Okay, if there's a lot of tricuspid regurgitation, again, if you're putting something into the RA and blood is mixing backwards and going backwards into the IVC, it gives you a very abnormal value. So thermodilution, normally you should have this smooth, rapid upstroke if there's normal cardiac output, and a slower decline. If there's high output, it goes up fast and falls fast because it clears out of the way very quickly. If there's low output, it takes longer for it to reach that distal port. It also takes longer for it to go away. I think I've used those. In terms of whether you should use a FIC or a thermodilution, if you're in the ICU, you can do both initially if they're fairly similar to each other. If it's cheaper to do thermodilutions, that's okay. It may be useful once a day to do a FIC. Again, as long as you're consistent in comparing apples to apples, it doesn't matter. Both of them have inaccuracies to them as long as you understand what those inaccuracies are. So these are tracings of what's normal. So C is what's normal, sort of a nice smooth upstroke, and then it falls. If you look at the curve in A, it reaches its max quicker and it decays quicker, so a high cardiac output state. A low cardiac output state reaches its peak later, and again, a slow decline. So the area under the curve is highest in B, and it's inversely proportional. So if it's a high area under the curve, it's a low cardiac output. Just like in AVO2 difference. So high AVO2 difference means a lot of extraction, a lot of difference between those two numbers, and there's high extraction because there's low cardiac output. D is if you start to inject and you don't inject smoothly, you're going to get bad tracing. So I think we just see numbers that spit out when the nurses do thermodilutions. If you're getting numbers that don't make sense, try to see if you can see their tracings and make sure that they look like they're reasonable. And again, this is putting all the curves together. So high cardiac output is very quick and gone. B is normal, so smooth up, smooth down. C is a low cardiac output. It takes a long time to get out there. And because it's sitting there slow, it sits there for a longer time, achieves a higher peak. And then D is just a bad injection. It's not a nice, smooth upstroke. That talks about TR. So when we look at our results, we're going to say, wow, we got our pressures, and we're going to use that to help us make a diagnosis. And now we have outputs. And so when we get our outputs and we say, this output, it's a big guy, his output is 8, his cardiac index is now 4.5, and we'd say, wow, that's a high output. Why is that? So can we explain it because he has anemia? Is he hyperthyroid? Is there cirrhosis or liver disease? Are they septic? Is there some other distributive shock? Okay. Is it low output? And we may know the reason, right? They may have terrible left heart failure, and we get a low output. Is there a lot of valvular regurgitation? So while the heart may squeeze well, if you have severe mitral regurgitation, flow doesn't go forward. So you're not advancing things. If you're just low volume, if you don't fill the tank, you're not going to have a high output, and you're going to have other clues. So if you have an output and you say it's really low, and the question is why, you can also look at your pressures and say, well, my right atrial pressure is low, my wedge is low, all of my pressures are low. It's probably low volume. And does that clinically fit with a GI bleed or some other thing? Or they're severely dehydrated. So you need to use your pressures, put them together with your outputs, and then you can also look at your resistances to help you. So let's look at a case. This is actually somebody that I cathed last week. So she's an elderly lady who came in for shortness of breath. She didn't have a prior known history of any kind of heart disease, and she had an echocardiogram with kind of a 35% EF, and that was new. She had been diuresed, and they wanted to see where they were getting. So she had an aortic pressure that was pretty normal, 132/74. She had a catheter placed. Her right atrial pressure was 9, so a little higher than 5. RV pressure, 56/10. And if we look, our RA pressure should be similar to our RV diastolic pressure, and it is. It's not exact, but it's close. Her PA pressure, again, her RV systolic and PA systolic should be similar. Again, PA diastole doesn't come all the way down. It's that triangular shaped thing, and the mean was 34. So a little higher than normal, which should be 20 or so. But her wedge was also high, so it was 24. And if we think about it, our PA diastolic should be something like our wedge if there's not some other problem. We did oximetry, meaning we got blood samples to measure saturation. So we got a femoral artery sat, which was 88, so she's a little bit hypoxic, so it's not our normal 95. And we got some mixed venous sats. We took 2 sats out in the pulmonary arteries, and those were about 54, so that's lower than we said 75 being normal. And she has hemoglobins that are 11 or 12, so a little low, but relatively normal. So if we'd say somebody's SAT is about 90 and about 54, that AVO2 difference is higher than our usual 20. So there's a big AVO2 difference, which should mean that our cardiac output is going to be a little bit on the low side. So her assumed oxygen consumption, and again, we took that from tables in the cath lab, and you can get it from other ways. We took our hemoglobin, we took this AVO2 difference, so 5.4 volume percent, and then we calculated cardiac output. Cardiac output is 4.3. She's not a very big lady. Her index was 2.1. So 2.5 to 3 or 3.5, 2.8 to 4 is normal. So she has low cardiac output. Her systemic vascular resistance is very high. Now remember, if you want to make this dynes, because that's what you understand, you multiply that by 80. So, 20 by 80, you're going to have 1,600 or something, which would be a fairly high SVR. And does that make sense with left heart failure? It does. She has a high wedge pressure. That is pushing pressure high all the way backwards. She has a lowish cardiac output. Her systemic vascular resistance is high. So all of that fits with fairly straightforward heart failure. And she's hypoxic for whatever reason. She has some pulmonary edema and or some lung disease. So straightforward case that makes sense internally. Okay. Remember that hemodynamics are a snapshot in time. So volume status matters, their pulse matters. Are they tachycardic? Are they bradycardic? Is there a lot of preload, meaning we've just given them several liters of fluid? Is there a lot of afterload? Do they have very high blood pressure? If we're going to get numbers, you need to make sure they're internally consistent, i.e., is our RA pressure similar to our RV diastolic? Is our PA systolic and our RV systolic similar? Are our LV pressure and aortic pressure similar? If they're not, you either have to explain why. Have we answered the question that we want to ask? And if we've found things, can we explain them? And if we can't explain them, we need more data. These are a few more examples. So this is an echo where there's a huge RV at the top and a huge RA at the bottom, and there's essentially no valve in between. So if we thought about this as one big chamber would we expect to see our normal tracing? So again, if I go in and get tracings and I look at them and I say, I don't even know where that comes from, it's not helpful. So these are the tracings from this person. Again, they're slightly on different scales. So the bottom one is on a 25 scale, the top is on a 50 scale, but they're actually fairly similar. One is from the RV, one is from the RA, and if you look at them, the shape is very similar. Is that a normal RA shape? It's not, right? We said there's usually tiny little ups and downs in our ACV waves. This looks more like a right ventricular tracing with a lot of square root sign, so it doesn't relax. And it's because, again, this chamber is essentially one big chamber. So when the RV squeezes, half of that blood is going backwards and changing the shape of our RA tracing. So you have to know where you are when you go in. This is from that person. We weren't sure why he had this. In fact, on that echo, although those chambers were very big, they squeezed very well. We weren't sure if there was a shunt that caused this or something else. So we got SVC sats, we got a nominate sat, which is like the brachial cephalic vein on the left. We got an RA sat, we got an IVC sat, and mixing all together, though they're not different from each other. So it didn't look like we were having any left to right flow coming in there. Our femoral artery or arterial sats were pretty normal. There's a little bit of a highish AVO2 difference. Again, our sats were 92 and 50s, not 70s. I don't remember his hemoglobin, and I apologize that I didn't put it there. His right atrial pressure is a little high, not surprising. We looked at those RV tracings. His wedge was okay. His pulmonary vascular resistance was normal. So this was all just tricuspid valve disease causing this. But again, if you don't understand what those tracings look like, you've got to be able to figure that out. When do we get a shunt run or a sat run? Sometimes if we have somebody who's hypoxemic and we don't know why. So they look like they have normal lungs, we're getting sats that are low, maybe we did an echo and there's a bubble study that's questionably positive. So we have some suspicion that there's an ASD or a PFO, or there's something on imaging that suggests that. Sometimes we have anomalous pulmonary veins. Those are harder to see and you're not going to necessarily see a positive bubble study. Or if we're doing our samples and we get a very high cardiac output, or our AVO2 difference is very low, which means, again, opposite, high output. If our PA sats are very high, that should tell us, something doesn't make sense here. And we need to figure out why. So you need to do a shunt run if you have to, unless you know the answer already. So i.e. they're severely anemic, or there's known cirrhosis or some other reason. We talked about these things a little bit earlier. Again, a little bit more on shunts. I don't expect you to be able to calculate the size of shunts and things like that. I just want you to be able to think about them. So this is a person who has a history of a repaired atrial septal defect, or so they told me. And when we got in there, we were not convinced of that because of some anomalies. And we found that the femoral artery sat was low. So she was somewhat hypoxic, although there's some degree of lung disease potentially. Her PA sat was 77. And so this mixed venous would be 77. 89 minus 77 is a very low difference here. So we said it should be 20. It's only about 13 or so, if that. And so we said, wow, that's not correct. Why is that? So we got a high SVC sat. That seems reasonable. So 69, close to our 7. But when we got into the right atrium, we found that that sat jumped. So our SVC sat should be the same as our RA sat. It's not. All of a sudden it went up, suggesting some sort of left to right flow is coming there. In this case, we also found a connection that we got a sat of 88, and this was actually an anomalous pulmonary vein. So the ASD is fixed, but there was an anomalous pulmonary vein that was never fixed. So there is an ongoing left to right shunt. The person didn't have a right to left shunt, so their FA sat isn't low because they have right to left shunt. It's because there's lung disease. Complications of putting in a swan or doing a right heart cath. So as we float the swan through the chambers, if we're running into the chamber walls, we can cause arrhythmias. So we get little runs of SVT or little runs of ventricular tachycardia. They're usually non-sustained. Remember that as you go through the right ventricle, the bundle branch goes across the bottom of the chamber, and you can hit that with your balloon, or you can get your catheter stuck underneath it, so that if the person develops a right bundle pattern when you're on the screen, you need to be careful of that, and you should put your balloon down and move your catheter. You have to think about if somebody already has a left bundle as their baseline pattern, and you're going to put a catheter in and you cause a right bundle, you've just caused complete heart block, so you shouldn't be blindly swanning somebody who already has a left bundle branch. If you put the pulmonary catheter up and you leave the balloon up, it's going to float out. And if it floats out and wedges itself and stays wedged, that area is not going to receive any blood flow, and you're going to have infarction of that pulmonary area. You can rupture a pulmonary artery after that. That is deadly. I think I've seen 1 or 2 people with that, and none of them are alive. You can perforate through a chamber. It's hard to go through a left ventricle because it's a very thick chamber. It's easier to go through a left atrium or a right atrium. It's a little harder to go through a right ventricle because, again, the wall's a little bit thicker. Usually our balloon is soft if we're using wires or other things. So EP studies, when we put wires in there, perforation can happen. Fluoroscopy helps us. Again, we don't often use it in the ICU, and we can just use pressure if you know where you're going. But if you're worried about it, you need to use fluoroscopy. If somebody has devices in their heart, i.e. a pacemaker or an ICD, you can't blindly float in there because you need to make sure your catheter's not hooking up on their pacer wires and you're not dislodging them. The other thing that comes up are constriction and restriction, and I don't expect you to exactly get this, but we can't look at one thing and always get the answer to know if someone has constrictive pericarditis or if this is just restrictive cardiomyopathy. If we're in there, though, and we get numbers that all seem very similar, this is how we tell. So we have to get simultaneous tracings, LV and RV. You're not going to do that in the ICU. You're going to have to go to the cath lab. But you can see at the top, most of the findings are the same. You're going to see a square root sign. You're going to see that there are elevated filling pressures. You're going to see that the end diastolic pressures are very equivalent. So you can't use those things by themselves. The thing to remember is that with constriction, there's discordance of the RV and LV pressures. So there's no other room. So if the RV expands, the LV has to shrink. If the LV expands, the RV has to shrink. So one goes up while the other goes down, and so they're discordant. If there's restrictive cardiomyopathy, the chambers can still move, and so you don't see that. And this is a picture of constriction. If you see, the top would be a catheter in the left ventricle, and as we breathe in and out, pressures change. Pressure is going up at the same time. The pressure is going down in the right ventricle. And so they are discordant, and that's constriction. If it's restriction, they should be concordant. So things go down and then go up. In the right ventricle, it's going down and going up. Both of them have that square root sign at the bottom, but you can see the difference there if you look at these pictures. This is a real tracing. So again, it's not as straightforward as the nice diagrams that you see in the book. So EKG's at the top, pressures are on the side. LV pressure is the higher pressures, RV, so there's a catheter in both chambers. They're zeroed together. And then we have the patient breathe in and out, and we watch over time. So they breathe in, they breathe out, pressure goes up, they breathe in, pressure goes down. And you can see that they track up and down with each other. So this is concordance, and it's a restrictive process. Stripping their pericardium is not going to help here. This is a gentleman who was sent to me ultimately after initially presenting with pleural effusion over and over and over again, and then someone decided he had liver disease, and then he saw me and he was essentially anosarchic, so he was having lots of ascites and edema, but it wasn't clear why. We put pressure tracings in, pressure again 0 to 50, average right atrial pressure here is 25. There's not a lot of respiratory variation. This guy was very big and he was just stuffed with fluid. If we then put his wedge pressure right on top of it, you almost can't tell the difference. Again, they're exactly the same. When we had a right ventricular tracing, again, we have that sort of square root sign to show that it's a non-compliant chamber. If we, again, measure the mean, it's exactly right on that 25. So we have an RA pressure of 25. We have RV diastolic of 25. We have a wedge pressure that's 25. We have somebody with anasarca that worries us. So we put a catheter in the LV and we put a catheter in the RV. The higher markings are the LV, the lower ones are the RV. And we had him breathe in and out. And again, if there's change in his pulse rate, things fall apart. But you can see as the LV starts to go up, the RV is going down. They are discordant. Another way of looking at is looking at the area under the curve. So this is the same tracings. We now have just spread out the timeline so that we can see things a little bit better. And you can see that the area under the curve, or the width of those RV and LV tracings, also changes. So not just the height. So if you look at, say, the fourth complex over, the RV is much thinner than the LV tracing. And if you go over 1, 2, 3 beats, the opposite. The RV is now as wide as the LV. So they're changing width and height on the bottom row. Same thing I've circled. And you can appreciate, I think, that some of the complexes are narrow while the others are getting wide. So this is somebody who had constrictive pericarditis. Tamponade is the other thing that comes up, and it's a continuum. Again, we're obviously not always swanning someone to figure this out. So you're going to think about if somebody has a very elevated LA pressure and RA pressure, they're wedged, they're all the same. They often have a prominent X descent and there's no Y descent. So when there's systole, there's nowhere for blood to go. So there's no change in pressure. But if you find someone that there's equalization of pressures, you've got to think it. Their systemic pressure is probably low, their pulse pressure is low, their pulse is going to be fast. Again, this is another way to look at this equalization of pressure. So we're just looking at the bottom of the LV tracing and we're looking at the top, the whole of the RV tracing, and you can see that they virtually run on top of each other. So the RV tracing mimics exactly the LV tracing and they don't change from one another. They don't relax normally, and they run right on top of each other. I'm going to skip this one, actually. This is somebody, again, a shunt run, so I want you to think about what we're finding here and try to put together what the history would be. So we have an SVC sat that's kind of high, so close to 80, and we said 70 is normal. A low SVC sat that's even higher. So we shouldn't go from the top of the SVC to the bottom of the SVC and have an increase in our sat. So something is wrong there. By the time we get into the right atrium and there's mixing going on, sats are even higher. We're able to get into a pulmonary vein, which means there's some kind of way of getting to that pulmonary vein, whether it's an ASD and we're able to get into the left atrium and then get into the pulmonary vein, or is there a pulmonary vein directly entering somewhere on the wrong side? IVC sat is 83, so it's high. It's higher than our SVC sat, which it should be, but it's overall high. Our PA sat, our mixed venous, right, we said should be 70 or 75. And it instead is 88. So it's very high, and we have normal femoral artery sats. So there's clearly a shunt here, and that step up occurs, it looks like, somewhere down near the low SVC or at the top of the right atrium. We got pressures at the same time, so our right atrial pressure was 8. It's not terrible. It's minimally high. Our PA pressure is a little bit high, 58 over 29, so the mean is going to be 35 or 36, so a little high. Our wedge pressure is not terrible. We measured cardiac outputs, and they're very high. So QP is pulmonary flow, 16 liters. QS is left-sided or systemic flow. Resistance is low, so this person has anomalous veins that are entering into his junction of his SVC and his right atrium. And because of this, he's got this very high output. He had this surgically repaired. So again, we can look at this person and say, we got these pressures, we got this very high output. Why did we get this very high output? We went back and did a shunt run. Actually, we did the shunt run on the way in because I suspected that there was something wrong based on his echo. But you need to be able to figure things out. This is not part of it, but I think I have a couple extra slides. Again, an LV EDP, as we saw some of those RV EDPs, where there's a rapid upstroke, just not a normally reacting. Those red lines on there are what it should normally look like at the bottom. This is a little bit harder. So this is advanced. This is a wedge tracing, I'm going to tell you that. I think you could look at those middle several beats and say, it's kind of a triangular beat. It looks more like a PA tracing, and the height of it wouldn't be terribly off for a PA tracing, but it's a wedge, and we know that because if you time it. So again, if you look at the QRS complexes on the EKG, you see that there's got to be a delay before ventricular contraction happens. So there's an atrial with a little glitch, and then there's a very large V wave. So that V wave is part of the wedge pressure, and it's because this person has bad either mitral regurgitation or some non-compliance of the left side. You need to be careful that you're not in a wedge position and think it's a PA pressure or vice versa. You keep thinking, I'm not wedging the catheter, and I am. And this here is a PA tracing. And if we look at that dichrotic notch at the top, it's very high, and it's a little bit unusual. It's not just a smooth triangle. It's got this little glitch in it. And you think, well, why is that? And when we then move to the wedge pressure here, again, it's not a normal-looking wedge pressure. You could almost look and say, these are on the same scale. Am I still in the pulmonary artery? I have this big triangular tracing. But here you don't. There's a little A wave, there's a big V wave. So this giant V wave is what's making this little glitch on this other PA tracing. And again, somebody with bad mitral valve disease. So you'd have to be very careful that you're not out there thinking, I'm still in the PA, I have a triangular tracing, when it's not. So time your tracings with your EKGs. More of the same. This is someone to show that volume matters and timing matters. So there's a wedge tracing at the top. You can kind of see a little jaggedy line. There's some respiratory variation. The mean wedge is probably 24 or so. We gave this person volume, just about 500 mLs, and showed that their V wave, suddenly there's a non-compliant left side. Their V wave goes up, and their wedge pressure goes from 25 to 30 or 35 very quickly. And again, it brought out the true physiology of this person. So it's not a stagnant thing. It's a point in time. That is all that I have. I think that I don't want you to memorize things. I want you to be able to think through as you go through your pressures in order of how you obtain them, and then you get your outputs. You have to be able to put everything together and think about whether those numbers make sense. And from that, you can then determine what you think is going on with the patient.